I'd like to introduce Dr. Greenblatt. He comes to us from Greater Boston area, and he's the Chief Medical Officer at Walden Behavioral Care. Many years of experience, I would probably say internationally known and respected. So really excited to hear your story on the fats of life. So I'll turn it over to you.
Great, thank you. It's good to be with you. I'll need to jump off at 1:15, and I'm hopefully we'll leave enough time for questions, because if there's one thing, I'm pretty confident that this topic will generate lots of questions, because I'm going to share with you what our medical colleagues have been avoiding or hiding or ignoring for probably over 30 years. And this is understanding the crucial role of fats for brain health. And particularly, we're going to address the role of low cholesterol. Yes, low cholesterol is a major component of the brain and how it affects addiction, suicide risk, and depression. So let's begin with our current model of suicide. So this is a Golden Gate Bridge. This was approved like 10 years ago, a $300 million metal net. There's a few of these in China as our suicide deterrent. No one wants to jump into a metal net. So you're right, every place where they placed a metal net, people don't jump, but suicide rates just continue to increase, as we're all kind of painfully aware of, as we have more programs and medications and apps and resources, but we just don't have what I think is an adequate biological model, and that's been my work over many years. So, we have this list of risk factors for suicide, and substance abuse is certainly one of them, but not much is looked at in terms of the neurobiology, and very little is done with the information, other than all these routine screenings and checklists that some agency wants us to do, but again, not moving the needle. So my work has been, what's the difference between those that come to our hospitals and clinics who thought about suicide, feeling hopeless and helpless, and those that actually make attempts and aggressive, violent attempts, like jumping off a bridge or hanging. And, my world changed about 25 years ago now, where it kind of ended up by mistake, wasn't on purpose, and running an eating disorder facility. This was the first patient. I was doing a family meeting over 20 years ago, and this woman with anorexia nervosa stood up on a chair in this family meeting and screamed at the top of her lungs, "You don't see what I see." And again, a shriek, and both her parents and I were a little stunned, but it was the beginning of my understanding that a patient with anorexia, that their brains are fundamentally different, quite distorted. It's not a disorder of willpower. But the other part of my eating disorder journey was something I did not learn in medical school or residency or 15 years out, that anorexia nervosa has the highest risk of suicide of any psychiatric illness. It's a second highest mortality rate, and next to overdose and addictions that you're aware of. But the majority of fatalities for patients with anorexia is not medical complications. It's not the heart attacks. It's not the low potassium. It is suicide. So that kind of got me on this journey 20 years ago about looking at the neurobiology of suicide prevention, which got me to where we are. So quickly, this is the model, many hours, but it's just taking the literature and turning it into a clinical, a workable model. So genetics is the simplest, but we're not going to go through it, but it is this kind of balance that's not, I think, addressed enough is that strong genetic family history, understanding 3 generations, and we can kind of fight with our genetic vulnerability, or kind of understand and dance with it. And the genetics of suicide, just go through 7 generations of Hemingway family to find out how powerful the genetics are in suicide prevention. And I'm just going through these quickly, but medications, again, we can talk about it and we can say there's a black box warning, but many people aren't addressing the other medications that have increased suicidal risk, as well as what to me is amazing is how many individuals on SSRIs with acute suicidal ideation that are second medications are added, not necessarily stopped. So medications, but in our presentation, we're not going to go through that. We're going to talk about nutritional deficiencies of fat. Fat deficiency. If you think of an anorexic patient, what is one macronutrient that they've avoided for 1 year, 10 years, 20 years? They're kind of phobic of fat. And I'm going to take you on a tour of fat deficiency and take you, and just in the back of your head, just think of that anorexic patient, highest risk of suicide of any psychiatric illness. So let's begin our journey. And it started, in the 50s and 60s with this guy, ANCEL Keys, who really took us on this very dangerous path. So we're not going to have time to go through it, but I would urge you to Google it, YouTube it, read about the ANCEL Keys in the 7-country study, which was kind of made up. A lot of the data was changed, but the punchline is this gentleman single-handedly in a very poorly done research study got the entire planet, mostly the American Heart Association, petrified of saturated fats. And that's our journey with polyunsaturated seed oils. So we kind of flipped this pyramid on the head and we started minimizing our use of fats and increased carbohydrates as an effort for health. And again, I'm not going to go through the literature. I'm not a cardiologist, but if you review the literature carefully, what we're all aware of, that the obesity epidemic is directly tied to this switch in minimizing fats. But the other concern that I will share with you is the mental health epidemic that we are facing is partly contributed to this as well. So think about it for a minute. 60% of the dry weight of the brain is fat. Every aspect, everything we ever learned in school, every medication, every physiological intervention that has to do with pharmacology has to do with cell membranes and cell receptors and fat, both the polyunsaturated fats, the omega-3s, and cholesterol, the saturated fats, are critical to every aspect of brain function. So I'm going to first take you on a journey, which I'm sure many of you know, just the essential fatty acids, the omega-3s, the fish oil, why fish is good for you. But I really want to focus on what is not discussed is why cholesterol is critical. Many of our studies on omega-3 and mental health and mental illness, both with suicide and addiction, it comes from the military. This Dr. Hiblin, who actually I just spoke with, who has been doing this work for many, many years, actually just left after 25 years, the NIMH, because they would not let him continue some of this research. But anyways, he started looking at these low levels of omega-3s and its association with aggression and suicide risk. And some of the first studies looking at military individuals, they had blood on everybody. Those that did complete suicide had lower levels of these essential fatty acids, the DHA. DHA levels, 62% were likely to have been suicide victims. So both the US government, based on the fact that the suicides and the epidemic of suicides in the military were not necessarily associated with PTSD or deployment. Here, 80% were not related to active duty service. So there's something else going on. And again, the research is extensive. It's not this talk, but you can just look it up. It's just quite significant. 25% greater risk of death, higher risk of depression, increased risk of suicidal ideation, right? Omega-3 fatty acids, why are we recommending salmon? We have 30 years of research. But the other thing that we might choose in our kind of lifestyle or dietary choices, maybe we'll order the salmon or recommend our children to eat salmon, but are we really integrating it into our treatment program? Are we really recommending omega-3s to our addiction patients? You know, we're providing medications that are costing the government or the insurance company thousands of dollars a month versus omega-3 pills, which might cost $20 a month. These were actual foods that the US military would enhance with omega-3 fatty acids because the literature was so clear. So they had a pound cake and a fettuccine Alfredo where they added omega-3 fatty acids in their many-year attempt to decrease depression and suicide risk in the military. True story. And then a few more omega-3s. So we have good research looking at augmentation. So this is just one of many studies. Taking omega-3 supplements improved remission on somebody taking Celexa. So 44% in the omega-3 group versus 18%. And these two studies I'm going to share with you, the last two I'm going to talk about for the omega-3 fatty acids and mental health. I think one of the most significant studies I've seen in psychiatry that got very little press and very little discussion among our colleagues. So in the Archives of General Psychiatry in 2010, 81 kids with subthreshold psychosis, that is a legitimate organized term in child psychiatry that we've been doing research on for years. The group was given a small dose, 1.2 grams of fish oil, maybe 2 pills you would get at the health food store, or placebo for 12 weeks. Those that took the fish oil, only 5% developed psychosis versus 28% in the placebo group. So a tiny dose of fat augmentation to a diet reduced the progression to a psychotic disorder. They followed these kids 7 years later. They had 71 of the 81. And again, no additional supplementation. The conversion rate for psychosis was 40% in the placebo group, around 10% in the omega-3. Again, small studies, didn't look at who was deficient, which does vary, and the dose is very little. But think of the implications, okay? We have omega-3, again, 20 plus years of research, decreasing risk of suicide, augmentation for depression, and here, preventing the onset of psychosis. To me, it's tragic that it's not incorporated into our treatment plans with literature much more extensive than we have for the multiple psychotropics that we are using. Again, this can be used with medication, but it's not a quick fix. We say it takes 3 months to change your oil because to replace these omega-3 fatty acids in the brain can take a number of months. So someone's not going to feel better if they're in a treatment program and you give them fish oil for a week. It takes time. Okay, so we've sort of read about it. You sort of know about it. you think about it, it's hard not to. Our kids know about it. But what is not as discussed, and what I rushed through the beginning, is cholesterol. I told you 60% of the brain is fat, and the brain is our most cholesterol-rich organ. Most of the cholesterol comes from manufacturing it in the liver. Only 15% comes from the food we eat, which kind of puts in perspective some of our obsession around dietary intake. Now, if you think about cholesterol, and this list could go on and on, but it is the precursor to all steroid hormones. I mean, we're aware of the cortisol, but there are 200 plus steroid hormones, from pregnenolone to DHEA. The list goes on, and particularly all our testosterones and sex hormones. Bile salt formation, critical for cholesterol. The synthesis of vitamin D on our skin is a cholesterol precursor. Brain receptors of serotonin are stabilized by cholesterol and oxytocin. Cholesterol is essential for life. And then, you know, it always takes Time magazine or the New York Times to get people aware. But this was some, you know, an article just looking at low cholesterol. And this is the research again: cancer rates, anxiety, stroke, drug addiction, school suspensions, aggression, depression, and suicide. We're going to focus on suicide risk and drug addiction. This, keep going, component of myelin, all neurotransmission depends on adequate cholesterol, and we kind of did that. So when did we begin to start thinking about this concept of serum cholesterol levels and suicidality? And it goes back to the 90s. And what I want to start right from the beginning is that when I'm talking about serum cholesterol, almost all the studies that I'll share with you are looking at total cholesterol. So we're not looking at LDL or HDL or any subfractions. We're looking at a total cholesterol number. Okay. So 1994, 584 patients, history of 1+ suicide attempts, the lower cholesterol, higher suicide attempts. 1994, Journal of Clinical Psychiatry. 1997, more research, cholesterol concentrations in the suicide attempts are significantly lower with both psychiatric patients and normal controls. Okay, so now we're talking about 25 years ago. And again, these are academic journals, biological psychiatry. These aren't our throwaway journals. And in 95 and 2014, similar patterns, lower cholesterol, twice the risk of making a medically serious attempt. And I wanted to kind of throw this one in because this is what kind of piqued my interest in 1999. So as an integrative psychiatrist, my career has always been looking at nutrition, nutrition and psychiatry, nutrition and health. So I was following this study, which had, I think it was over 30,000 individuals. It was a Finland study, and they were giving beta carotene to see if that prevented cancer. So one, it did not prevent cancer, so they stopped the study in between, but they found this subset of individuals that had died of suicide in this long study, as well as hospitalized for severe depression. So they took out this group. They weren't looking at depression or suicide risk. They were looking at cancer prevention. And they found low serum total cholesterol was associated with this group of individuals that were dying, getting admitted to psych hospitals, and completed suicide. So that was 1999. And I can just share with you, the literature continues. And what I'll share with you now before I go through some more of these studies, which is only me feeling defensive, because if you bring this up to any of your colleagues, certainly if they have a cardiology degree after their name, they would think this is kind of just a bunch of baloney, because it's very hard to convince our colleagues of this really pretty significant literature. But what I wanted to make sure we discussed is the total cholesterol associated with higher mortality rates due to suicide or total cholesterol numbers under 140. Okay, total cholesterol under 140. Some of the studies were under 150, but for our purposes, the vast majority looked at, when they talk about low cholesterol, we're talking about total cholesterols under 140. Now, when you go through the literature and clinically, I'll share some cases with you. What is quite striking about these very low cholesterol individuals is they tend to have a high lethality suicide attempts. This is gunshots and hanging. It's not typically the pill overdose or the risk cutting. There's something about this very low cholesterol, both in the literature and in my clinical experience, that these are high lethality attempts. So here's a 2019 study, again, a reputable psychiatric journal, 432 attempters, blood collected within 24 hours, and same high lethality, lower total cholesterol. Older study, but I just wanted to point out this kind of aggressive, violent attempt with lower cholesterol. And here they were able to compare with the non-violent suicide attempts. Patients with violent suicide attempts often have this very low cholesterol. And there's more. I don't want to bore you with studies, but I just need to kind of hit you over the head so you can ask some good questions. And one, we can start looking at total low cholesterol. It's a much older study, but again, low cholesterol associated with aggression, violence, substance abuse, and here a diagnosis of intermittent explosive disorder. I will repeat, the brain is 60% fat. Nothing works optimally without adequate omega-3s, 6s, and cholesterol. Cholesterol is just integral to stabilizing many of these receptors, serotonin in particular. So let's get a little more gruesome here. Post-mortem brain studies, right? We have thousands of brains in these brain banks now. And they've been, this is one of many studies that I've seen, but we take age-matched control, someone that died of a motor vehicle accident. Okay, so we have a 21-year-old who died of a motor vehicle accident and compared their brain to a 21-year-old who died of suicide. And some of the studies just had lower cholesterol in the brains. And this one looked again at the violent suicide completer, lower gray matter in the post-mortem analysis. There's just less cholesterol in their brains. Okay, so let me tell you about my world. The 20 years I was running an eating disorder facility, we continued to have a inpatient psychiatric unit. So for 24 beds. So for 20 years, I was director of an inpatient psychiatric unit. I gave a talk to my staff about low cholesterol. And I don't know about where you guys practice, but lipid panels are not routinely done in emergency rooms for admission to a psych hospital here in Massachusetts. So it's just not routine. Occasionally, if someone's starting antipsychotics and someone wants to monitor glucose and triglycerides, yes, but not on a mission, not routine. So we did this for a few months at our expense, since insurance would not cover lipid panels in a psych hospital. And his first staff member came to me with an 18-year-old, multiple suicide attempts. This admission was his third suicide attempt. And he was lucky to be alive. His father came home by accident, and his total cholesterol was 69. 18-year-old total cholesterol, 69, right? Unrelated to diet. These cases I'll share with you are all not necessarily concerned about health or fat. They were eating a typical American diet for a teenager, which I'm sure was loaded with cholesterol. And then for that rest of that month, these are other cases on our inpatient unit. The 119 was a female, the cholesterol, the 110. These are all young adults, 18 to 22, with suicide attempts being admitted to our inpatient unit. Now, the tragedy is this is not routinely done. Hopefully I showed you there's literature and more literature. And so then we have a summary of the summary. So a biomedicine, review 2021. The data from the existing literature relate low cholesterol and pathophysiologic mechanisms for participation in suicidal behavior. So our academic scholars review the literature and say, well, guess what? It's really hard to ignore this literature. So there's some relationship, but there's no clinical implications. I read an article, it was actually right before COVID. It was a brilliant article summarizing all of the literature similar to this one. And the last paragraph said, we still have to do more research. I was completely blown away because the beginning of the 4 pages with hundreds of references, I finally said, wow, maybe this is gonna kind of make sense now and we'll do something about it. But they said we need more research. I think we're all familiar with pharmaceutical research where drugs get approved with 28 patients, one study funded by the drug company. Okay, so let's think for a minute. What has our no-fat, sugar-free, low-fat world done to our obesity epidemic? Well, I mean, it's quite clear. It has contributed. So this kind of no-fat, sugar-free craze has not helped. And hopefully I'm sharing with you some of the disruption in our mental health. The addiction literature is not as robust, but it exists, okay? 20 years ago, a non-opiate or cocaine-dependent, alcohol-dependent cocaine addicts looked at total cholesterols. Again, we're not talking about any fractions. It's total cholesterol. And here, total cholesterols were lower in patients who relapsed at 3, 6, and 12 months after discharge. So much of the work that you guys do is kind of relapse prevention. We know it's such a huge part of addiction treatment. And how do we predict? Well, in my experience, I can also share with you hundreds, if not thousands, of very, very low cholesterol patients. Relapse on addiction is common. Here's that study. And then heroin cravings, again, 10 years ago, looking at total lipid panels, 70 heroin users. Here they did break it down, but total cholesterol negatively associated with heroin cravings. The brain's just don't work well. Methamphetamine use, decreased total cholesterol observed in these 938 patients. 2017 study. Now this, I have no research, but I can tell you this has been my clinical world for 25 plus years. I have found an association. I do not have research to support it. But these kids with very low cholesterol that I've seen in the office, not for these violent suicide attempts, are those individuals that are severely dependent on cannabis. Again, no research to support it, just an association that I made and that I continue to see. These individuals can't stop. They're in treatment programs and they can't stop. They're on medications and they can't stop. Only when we're able to increase their cholesterol have I been able to help wean these patients off of cannabis. So it's my clinical association. Now, I do want to kind of share the kind of statin question with this very low cholesterol concern that I'm talking about. So this was a book by Dwayne Graveline, a surgeon who started taking statins and completely lost his memory. He's written, I think, 2 books now on the cognitive changes on statins. This book is Thief of Memory, was his first. And what I'm sharing with you is that, and now we have this, FDA warning about cognitive changes on statin. The work that I went through very quickly on low cholesterol is different than the cholesterol decrease that we see on statins. Now, over the years, I've seen many individuals who've been placed on statins many years ago, not monitored. We watched their cholesterol go from 220, and 10 years later, it's hovering around 150 or 160. They have memory problems. They are depressed, and stopping the statin, their cholesterol creeps up a bit and these symptoms improve. So the cognitive changes on statins are real. There's now an FDA warning, from our cardiologists or PCPs. Nobody would really know, not quite sure if that informed consent is given, but it is real. But it is very different than the very, very low cholesterol that we get in these young adults. The very low cholesterol that I'm referring to is likely genetic. It's not a clear cause. Usually somebody in the family has low cholesterol, might not be as low. And there are genetic syndromes with very low cholesterol where aggression is a part of it. But kids that we're seeing, not diet related and not statin related. Here's some, just the other post-mortem study looking at cholesterol. So just want to throw a few more cases out there. And then, we're going to have plenty of time for questions. I went through this very quickly. So hopefully you'll gather your questions. But just to kind of demonstrate, how often we see this. This is a 17-year-old male, depression, suicidality, and benzo and THC abuse, family history positive. We see a total cholesterol here of 92. You also see vitamin D levels, which are a routine test that I think should be done on all of our depressed and patients with addiction, because vitamin D is made from cholesterol, and vitamin D is critical for the synthesis of serotonin. But here you see total cholesterol of 92 and that THC and benzodependence. Female, again, I would say 70% or so of the young adults I've seen with this very low total cholesterol are males, but occasionally we see a female. Here, again, lots of reasons why somebody might be depressed or thinking of suicide. We have a mood disorder diagnosis, physical and sexual abuse, cutting, and chronic marijuana use. So we just kind of chalk it up to the psychosocial, the stress, the trauma, but look at her total cholesterol of 106. So again, we have all these risk factors. So this patient presents to the emergency room with a suicide attempt. We might call the patient depressed. We might call the patient borderline. We might call the patient bipolar. We're going to say it's a trauma history, or we're probably going to say addiction. And we have all these labels, and we're going to just kind of draw that line that is why she's at high risk for suicide. And nobody's looking just a little carefully at any biomarker that might help articulate that. A total cholesterol is a significant biomarker for suicide risk. Okay, as a 47-year-old, again, aggressive, violent, suicide attempts, multiple diagnoses, aggression, jail, inpatient, chronic addiction. Total cholesterol of 87. Okay. The history is, what we see, what you see, and nobody's looking at biomarkers with total cholesterol of 87. So I guess someone is going to ask, okay, we can do a blood test. It costs $27. Someone's got to pay for it. And we get this total cholesterol on a chronic relapsing addiction patient with multiple suicide attempts. What do we do? Well, that is more challenging. Dietary intake of cholesterol is important. Eggs are probably the richest source. Depending on the egg, 2 to 250 milligrams of cholesterol. So we are asking our patients to eat eggs 2, 4, 6 a day. You should not worry about saturated fat and or heart risk. There are more micronutrients in eggs than most of our superfoods that we're trying to sell in the health food store. But either way, eggs, as well as we're recommending digestive enzymes. What are digestive enzymes? Well, these are the lipases that we actually use. Sometimes I use the prescription brand that they used to use for cystic fibrosis. So we use, it's called Creon, but you can get them over the counter, digestive enzymes, to help the individual who is eating adequate fat digest and absorb. So digestive enzymes with bile acids and lipases can be helpful. And probably the most controversial is there are cholesterol supplements. So for some of our lowest cholesterol, for some of the patients that I've been able to follow from a hospital to outpatient, we've been able to utilize cholesterol supplements. They're actually made from sheep skin, and they're food grade, FDA approved supplements where we use between 2 and 6 a day to increase total cholesterol, and we see improvement in mood and suicidality and addiction relapse prevention for addiction. Dietary changes first, digestive enzymes, and cholesterol if we need them. So it's an old quote, but I like it because it speaks again to this concept of fat in the brain. And think about what we've done since I was a kid in the 60s when we started buying, what was it, Fresca and Tab, and everything was fat-free. So obesity epidemics went up, chronic illnesses went up, mental illness went up. So this Franklin Institute, by modifying the natural fats in our diet, we've altered the basic building blocks of the human brain, weakening cerebral architecture, and like unstable buildings that come apart in an earthquake or storm, poorly structured human brains are failing to cope with the mounting stress of modern life. I am particularly worried about our vegan adolescents, that in a time of rapid development, where brain development is continuing into our 20s, where myelin is not all laid down and formed, that inadequate fat has, I think, profound, irreversible implications for adolescent development. And again, I'm hit over the head with this, with our patients with anorexia nervosa, who are completely avoiding fat, their cognitive distortions, their depression, anxiety, and suicide risk is really striking and documented in the literature and tragic. A failure to have adequate fat results in increasing rates of mental illness. Anorexia is an extreme. We have healthier vegan adolescents that aren't eating adequate fat, and their mental health is suffering. And we have research supporting adolescent vegetarian vegan diets have worse mental health than their peers. So belaboring the point, but here's a meta-analysis over 500,000 people. Guess what? Same thing, lowest total cholesterol. And I've heard it, I've said it enough, but maybe we can never say it enough. Higher risk of suicidality, higher attempts, and suicide completion. I mean, every time I give this presentation, I get more enraged that our emergency rooms aren't paying the $27 for a lipid panel. Our psych hospitals, our addiction programs aren't routinely looking at low cholesterol and identifying that high-risk individual. In my original slide, where I have this kind of biological model where total fat is just one of many other parts of this model, I mean, let's think about it. If we add deficiencies in other micronutrients like folate and B12 and vitamin D, all associated with suicide risk. We talked about genetics. Do we take a careful medication history? The clear implications now and research supporting sleep deprivation, increasing suicide risk. The clear research now documenting higher levels of inflammation. So looking at inflammatory markers associated with suicide risk. History of concussion and traumatic brain injury, increased suicide risk. And then, chronic stress and trauma, we are more sensitive to. But if we bundled those biomarkers and looked more carefully at inflammatory markers and low cholesterol, wouldn't we be able to think about a model of prevention? Wouldn't we be able to identify that high-risk individual who came in after a hanging attempt in the emergency room? Or do we just send them home if there's no beds, or put them in a hallway, or send them to the psych hospital where a third or fourth medication is added? I will share with you, part of the reason we get to see these kids so much is the very, very low cholesterol kids are not as responsive to medications, either antidepressant or mood stabilizers, as those with normal cholesterol. So to put it in perspective, The New England Journal of Medicine, 1989, looked at this cholesterol problem. Again, let's go back, 1989. And they were able to demonstrate, yes, if we lower your cholesterol, you're going to have less heart attacks. Now, there's some controversy in that literature, but let's just, for the cardiologist friends, neighbors, let's just say, okay, we lower total cholesterol, less heart attacks. But look at this from 1989, the all-cause death rate almost doubles. Look at under 140, your total cholesterol, the all-cause death rate per 10,000 is almost double, if over 300 compared to 172. There's something wrong with this picture. The blindness of our medical colleagues of thinking the lower cholesterol, the better, has done tremendous damage to our high-risk, vulnerable, particularly genetically vulnerable psych patients, genetically vulnerable addiction patients, because those that end up with these total low cholesterol, either due to statins or that has this genetically vulnerable total low cholesterol, is being ignored when they're seen. Low-fat diets don't work. I eat fish every day and my butt still drags on the ground. And there's some humor in our obsession with kind of low-fat, and even though the research has really contradicted the 60s research. So I'm going to end with plenty of time for questions. So be happy to take them, live if you want to unmute or type it into the chat room. But I think I've said it enough. Every aspect of brain function is dependent on optimal workings of our cell membranes, which require saturated and unsaturated fat. It affects neurotransmitter signaling. Deficiencies have, in the literature of over 30 years, low cholesterol, aggression, suicidality, impulsivity, psychosis, and I shared with you a few slides on addiction. When we supplement, we need to make sure we give omega-3 and again, monitor cholesterol levels. The educational platform that I started a number of years ago, Psychiatry Redefined, we have this ketogenic diets in psychiatry program with, I think, some great speakers who will outline the myth of saturated fat in cardiology, but these speakers were all focused on ketogenic diets in psychiatry, high-fat diets in psychiatry, and there's been a couple recent books out. Dr. Palmer from McLean wrote a book on ketogenic diets in psychiatry, and the research is really more extensive than most of us are aware. So that is where I will stop, and certainly be available for any questions.
Well, thank you, Dr. Greenblatt. That was fantastic, and I'm sure we have some questions from folks. I don't want to go first, so I'll open it up. Does anyone want to chime in?
I have a question.
Go ahead.
So I really enjoyed your presentation. I am somewhat ignorant to cholesterol levels, obviously, but so do you think that a major reason why this research isn't talked about, despite it being around for a very significant time in terms of like research standards, like, do you think it's not discussed because our focus as a society, especially American culture, is on the obesity epidemic and controlling diets in the other direction?
Yeah, I think it's twofold. One is our cultural obsession, in terms of lifestyle and health, that fat is bad, right? Even though, avocados are making a comeback and people are talking about fat. But Yeah, so that, but that hasn't changed. You can sit around a dinner table and, 8 out of 10 people will still feel that they can't eat the butter or the avocado because of the fat. So that the cultural, but I think the medical is even more entrenched in this cholesterol being evil. And the statin industry was $1 billion industry 20 years ago. So, who knows where it is now. And statins are being recommended for every known medical illness as an augmentation strategy. So I think there's a pharmaceutical bias as well as a traditional medical bias that just complicates things. As a psychiatrist into nutrition, I can list 30 other things that I would recommend to patients, from B12 to zinc, but none of it has the extensive, well-done research that low cholesterol does.
Dr. Greenblatt, is there a familial component of low cholesterol? Does it run in families, or is this, besides the obvious kind of not eating, or a lot of your anorexic patients that get low LDL levels, is there that familial component?
Yes.
Because I know there's a familial component the other way, right? A lot of folks have high cholesterol in their family. I'm wondering about low cholesterol.
Yes, 100%, particularly these very low cholesterols. There's usually someone else in the family. Now, as a community, we first started becoming aware of it in the autistic world, because there's a couple syndromes, and don't ask me the name, but there are a couple genetic syndromes where they have very, very low cholesterol, and autism and aggression is part of that. So we know there's a genetic enzymatic reaction for some individuals. And usually there's some members of the family that might have low cholesterol, might not get to that under 100, and they might not struggle with depression, but they were told, yes, you have low cholesterol.
And is it mostly LDL that you're looking at, or is there a difference with triglycerides, LDL, HDL?
No, it really doesn't. Some of the literature, what's good for the heart's good for the brain, but this is really just based on total cholesterol. So not any fraction. So it's the total cholesterol, the simplest test, the simplest marker, under 140, significant risk factor. Under 100 is, I think concerning. And those are the kids we're seeing getting admitted to the hospitals, and the kids that are chronic substance abusers.
Now, besides eggs, what foods would you recommend for patients that, a lot of our patients come in and, they have opioid addiction, they might not be eating well. Are there certain things, nausea, vomiting associated with withdrawal? Anything in particular that you recommend, that we recommend for our patients?
Well, I think one, not being afraid of fat and helping identify, that fat's not evil. And then, sometimes it is the digestive enzymes to help them, or, bile acid, digestive enzymes, either over the counter or the prescription Creon, which will help them kind of digest the fat.
All right. Well, thank you. Any other questions from anyone in the group? Otherwise, I think we'll let you carry on, Dr. Greenblatt. Thank you for participating today and for all your good work. I'm sure we'll hear more about this.
Great. Yeah, just look at a couple lipid panels. And again, it's not everybody, but if it's 5, 10, 15%, these are our treatment refractory patients. So thanks for your time. I appreciate the invitation. Take care.